My name is John Rourke. I'm a cardiologist at Brigham and Women's Hospital and a cardio-oncologist at Dana-Farber Cancer Institute. This morning I will deliver a short review of key topics in the field of cardio-oncology. These are my disclosures. This is the outline of the talk. I will begin by discussing some key principles in cancer epidemiology, then spend some time discussing the cornerstones of cardio-oncology, specifically radiation-induced heart disease and anthracycline cardiotoxicity. I will then explore the established and emerging cardiotoxicities associated with newer targeted anti-cancer agents and immune checkpoint inhibitors. Let's begin with some board-style questions that you can be considering throughout this talk, and we will return to them at the end of the lecture. The first question. Additional anthracycline-based chemotherapy is planned for a 42-year-old lady with metastatic breast cancer and prior exposure to 320 milligrams per meter squared of doxorubicin. Current EF is 56%. The only FDA-approved agent or agents to protect against anthracycline-induced cardiotoxicity in this patient is or are A. enalapril, B. enalapril and carvedilol, C. desrazoxane, and D. statin. Second question. 69-year-old lady with no significant cardiovascular risk factors has been treated with thalidomide and dexamethasone for multiple myeloma. Which of the following cardiovascular complications is she at highest risk of? A. dilated cardiomyopathy, B. prolonged QTc, C. atrial fibrillation, or D. venous thromboembolic disease. Question C. 69-year-old man with a history of hypertension, peripheral arterial disease, smoking, and COPD, EF of 52% with abnormal diastology, has been recently diagnosed with CML. Which of the following is most true about BCR-ABL tyrosine kinase inhibitor therapy? A. serial EF assessment is recommended throughout treatment. B. aspirin should be interrupted due to anticipated thrombocytopenia. C. dasatinib is the preferred BCR-ABL tyrosine kinase inhibitor as it has a more favorable vascular safety profile. And D. use of BCR-ABL tyrosine kinase inhibitor is contraindicated for this patient. So let's kick off with some cancer epidemiology. Firstly, cancer is on the rise. Approximately 2 in every 5 people will be diagnosed with cancer at some point during their lifetime. This graph illustrates projected cases of all invasive cancers in the United States by age and sex. The total projected cancer incidence will increase by approximately 45%, from 1.6 million in 2010 to 2.3 million by 2030. This increase is predominantly driven by cancer diagnosed in older adults. Of course, with increasing age comes increasing comorbidities, and certainly the incidence of cardiovascular disease increases with age. On this graph, we have the incidence of cardiovascular disease by age and sex from the Framingham Heart Study. So we are seeing older cancer patients who either have pre-existing heart disease or who will develop cardiovascular disease during their treatment. Indeed, when one considers that cardiovascular disease and cancer are the 2 leading causes of death, it's no surprise that these disease processes will coincide in patients. Substantial improvements in cancer care have improved 5-year survival for all cancer sites from 49% in 1980 to 69% in 2007. It is estimated that there are approximately 16 million people living with cancer in the United States, and there are over 3 million women with a breast cancer diagnosis. Cardiovascular disease is a leading cause of death in cancer survivors. And for these reasons, cardio-oncology has emerged as a new subspecialty within cardiology to address cardiovascular issues in cancer patients. Let's now turn our attention to radiation therapy. Approximately 50% of cancer patients receive radiation therapy at some stage during their illness, and radiation therapy is associated with significant improvement in disease-specific and overall survival. Cardiovascular complications associated with thoracic irradiation were first described in the 1960s, and we now recognize that thoracic irradiation can be associated with acute cardiac injury, more common late cardiac injury where it can affect the coronary arteries, the pericardium as chronic pericarditis, the myocardium as a restrictive cardiomyopathy, the valves resulting in mixed valvular disease, and conduction abnormalities. It can also cause a medium or large vessel vasculopathy to the point of porcelain aorta. Cancer survivors who receive radiation to the chest demonstrate significantly increased relative risk of ischemic heart disease, valvular heart disease, pacemaker implantation, congestive heart failure, and cardiovascular death. And this is particularly true for survivors of mantle radiation used in the treatment of Hodgkin lymphoma that previously involved delivering 36 to 45 Gray to the chest with significant incidental exposure to the heart. Risk factors that predispose to radiation-induced heart disease have been described. These include anterior or left chest radiation, high curative doses of radiation, young age at the time of treatment, radiation fractions exceeding 2 grays per day, tumour that is adjacent to the heart, lack of cardiac shielding, concomitant chemotherapy, especially with anthracyclines, pre-treatment cardiovascular risk factors, and pre-existing cardiovascular disease. Patients who have received anterior or left-sided chest irradiation who have one or more of these risk factors are considered to be at high risk for radiation-induced heart disease. A landmark study in the field was published in 2013 by Sarah Darby and her colleagues at Oxford on the risk of ischemic heart disease in women after radiation therapy for breast cancer. They studied over 2,000 women treated between 1958 and 2001. 963 of these women had a major coronary event, which was defined as MI, coronary revascularization, or death from ischemic heart disease. The mean dose to the whole heart in the study was 4.9 Gray. On this graph, the percent increase in rate of major coronary events are plotted on the y-axis, and the mean dose of radiation to the heart is plotted on the x-axis. They found that the risk of major coronary events increases linearly with the mean dose to the heart, such that the rate increases by 7.4% per Gray of radiation delivered, and there is no apparent threshold below which there is no risk. The cumulative incidence of any cardiac diagnosis, shown here by the solid black line, and of cardiac procedures, represented by the broken line, increases significantly approximately 10 years after a median dose of 40 Gray to the mediastinum was delivered in Hodgkin lymphoma survivors. Such data underlie guidelines that endorse stress testing at 10-year intervals after treatment is completed in survivors of Hodgkin's lymphoma. Indeed, the American Society of Echocardiography and European Association of Cardiovascular Imaging released a consensus statement in 2013 that also endorsed interval stress testing for asymptomatic, high-risk patients 5 to 10 years after exposure. However, it is important to keep in mind that there is an increased risk of coronary events even within the first 5 years from radiation therapy. In the Darby study, there was a 16.3% increase in rate of major coronary events per Gray even within the first 5 years following radiation therapy. So what do we do when we find coronary artery disease in radiation patients? Last year, this study compared outcomes in radiation patients versus non-radiation patients undergoing PCI. The study employed propensity matching using both clinical and lesion characteristics. And there was no difference in the rate of PCI complications or in all-cause or cause-specific mortality during follow-up. However, radiation-associated coronary artery disease often presents a particular challenge for the cardiac surgeon. They will often have multiple cardiac lesions and so rarely require just an isolated bypass surgery or isolated valve surgery. Coexisting radiation-induced pulmonary disease increases the risk of perioperative respiratory complications. Aortic calcification to the point of porcelain aorta can also result from radiation injury. And this is why these patients should have a non-contrast CT chest performed prior to cardiac surgery to assess the extent and location of vascular calcifications for surgical planning. Radiation can result in fibrosis of the internal mammary artery, rendering it unusable as a graft at the time of bypass. Pre-bypass planning in these patients should therefore also include angiography of the internal mammary arteries. Extensive tissue fibrosis can make for a hostile chest, and traditional risk scores will underestimate true risk because they do not consider prior radiation therapy and/or chemotherapy. Adverse outcomes following cardiac surgery in patients with radiation-induced heart disease were highlighted in this study from the Cleveland Clinic. They compared outcomes of 173 patients with radiation-induced heart disease with 305 non-radiation patients, matched according to age, sex, and type of cardiac surgery. The mean age was 63, 75% were women, and this reflected the fact that the indication for radiation therapy was breast cancer in 53%. The calculated Euro score was similar in both cohorts, and about 2/3 of each group were undergoing combination surgical procedures. This table highlights that the post-operative length of stay was much longer in the radiation cohort, post-operative AFib was more common, and more radiation patients required pacemaker implantation. During a mean follow-up of 7.6 years, radiation-induced heart disease was associated with a 2.5-fold increased risk of death compared to non-radiation controls. And radiation patients who already had cardiac surgery did particularly poorly. So let us now turn our attention to anthracyclines. Anthracyclines are highly effective chemotherapies used in the treatment of many solid and hematological malignancies. Their anti-cancer effects are mediated by intercalation into nuclear DNA to impair protein synthesis, production of reactive oxygen species, inhibition of topoisomerase II. So topoisomerase is an enzyme involved in DNA transcription and replication, and it's a key target of anthracyclines. There are two isoenzymes of topoisomerase, TOP2 alpha, which is expressed in rapidly dividing cells, and TOP2 beta, which is expressed in non-rapidly dividing cells, such as the myocytes. TOP2 beta was recently identified as a key mediator of anthracycline-induced cardiotoxicity. TOP2 beta inhibition by anthracyclines causes double-stranded breaks in the DNA, which can lead to cardiomyocyte death. In addition, there is anthracycline-induced production of reactive oxygen species. And furthermore, TOP2 beta is critical for mitochondrial biogenesis, and so inhibition results in mitochondrial dysfunction. These mechanisms mediate cardiotoxicity and result in myofibrillar disarray and vacuolization of the cardiomyocytes. The classic teaching identifies three types of anthracycline-induced cardiotoxicity. The first type is acute, and it's rare, and it's considered generally reversible. Then there is early onset chronic cardiotoxicity and late onset chronic cardiotoxicity. These types are more common and generally considered less reversible, if not irreversible. However, it's now generally considered that anthracycline cardiotoxicity in fact represents a continuous spectrum of toxicity that is identified at different stages. This was a great study performed by Daniela Cardinale and her group in Italy. They prospectively performed regular EF assessments in 2,625 patients receiving anthracyclines. Cardiotoxicity in the study was defined as a decrease in EF by greater than 10 percentage points from baseline and less than 50%. And the overall incidence of cardiotoxicity in the study was 9%. The median interval from the end of chemotherapy to cardiotoxicity was only 3.5 months, and 98% of cases actually occurred within the first year. When discovered early and treated early, 11% of patients enjoy a full recovery and 71% demonstrate partial recovery. And only two factors were independent correlates of cardiotoxicity, and they were EF at the end of chemotherapy and cumulative doxorubicin dose. Risk factors that predispose to anthracycline-induced cardiotoxicity are recognized. These include extremes of age, female sex, combination of anti-cancer agents, particularly trastuzumab, prior exposure to anti-cancer agents, radiation therapy to the mediastinum, baseline LV dysfunction, cardiovascular risk factors, and cumulative dose of anthracycline. There is an exponential increase in the risk of cardiomyopathy with increasing lifetime cumulative dose of anthracycline. The risk is especially high in children treated with over 250 milligrams per meter squared, and it's lowest among those treated with less than 100 milligrams per meter squared. But importantly, there appears to be no clear cutoff for a safe anthracycline dose, as symptomatic cardiomyopathy has been reported in survivors who received doses well below 250 milligrams per meter squared. So how can we prevent anthracycline cardiotoxicity? Well, patients should undergo pre-treatment cardiovascular screening, and any cardiovascular comorbidities should be optimized prior to treatment where possible. There are some data to suggest that lower peak plasma concentrations associated with continuous infusions compared with bolus delivery are associated with less cardiotoxicity, but comparable anti-cancer efficacy. Liposomal encapsulation of doxorubicin is thought to restrict doxorubicin to inside the vessel wall of healthy organs, and yet it more readily penetrates through the more fragile and permeable tumor vasculature. Thus, doxorubicin's anti-cancer properties are preserved with less cardiotoxicity. However, because of its cost, liposomal doxorubicin is not widely used, and it is only approved by the FDA in certain cancer types. Cardioprotective pharmacotherapies that have been investigated in preventing anthracycline cardiotoxicity include desrazoxane, ACE inhibitors or ARBs, beta blockers, and combinations of ACEs or ARBs with beta blockers, and statins. Desrazoxane is a derivative of the metal chelating agent EDTA. This reduces anthracycline cardiotoxicity through iron chelation, reduced production of reactive oxygen species, and it also binds TOP2, preventing anthracycline from binding to the TOP2 complex. In this study, more than 500 patients with advanced breast cancer undergoing anthracycline chemotherapy were randomized to receive either placebo or desrazoxane. A cardiac event was defined by a nominal EF decline or development of heart failure, and the hazard ratio of placebo to desrazoxane for cardiac events was 2.63. Desrazoxane is the only FDA-approved agent to protect against anthracycline-induced cardiotoxicity for women with metastatic breast cancer due to receive greater than 300 milligrams per meter squared of doxorubicin. However, it is not widely used in clinical practice due to concerns regarding reduced anti-tumor efficacy because it binds TOP2 alpha as well as TOP2 beta, and also concerns regarding increased risk of secondary malignancy, although this is now considered less likely. Beta blockers, ACE inhibitors, and ARBs have been evaluated in randomized controlled trials for primary prevention of anthracycline-induced cardiotoxicity. The major limitation of these studies is the short duration of follow-up. As you can see from this table, results are somewhat mixed, and it's fair to summarize by stating that whether beta blockers, ACE inhibitors, or ARBs are useful in primary prevention of anthracycline cardiotoxicity is uncertain. So let's look at some of those trials. Well, the Overcome trial randomized 90 patients with hematological malignancies to an allopril and carvedilol combination versus placebo. Echo and cardiac MRI were performed at baseline and at 6 months after randomization. There was significantly less reduction in LVEF in the intervention group, as well as a lower incidence of the combined outcome of death or heart failure, so 6.7% in the intervention group versus 22% in the control group, which was statistically significant. The PRADA trial randomized 130 women with early breast cancer embarking on anthracycline chemotherapy with or without trastuzumab to candesartan, metoprolol, or matching placebos in parallel with chemo. The primary outcome was change in CMR-derived LVEF. They found that candesartan, but not metoprolol, prevented a modest short-term decline in EF. And they concluded that in patients treated for early breast cancer, concomitant treatment with candesartan, but not metoprolol, provides protection against an early decline in global LVEF. The CC trial was published this year. It evaluated the role of carvedilol in preventing anthracycline cardiotoxicity. 200 patients with HER2-negative breast cancer with normal EF received 240 milligrams per meter squared of doxorubicin and were randomized prior to treatment to receive either carvedilol or placebo. In this scenario, carvedilol had no impact on the incidence of EF reduction at 6 months. However, the use of carvedilol did result in significant reduction in troponin levels and incidence of diastolic dysfunction. Statins have been studied to a limited extent in primary prevention of anthracycline cardiotoxicity. In a retrospective cohort study of over 600 cancer patients, uninterrupted statin use resulted in reduced heart failure. In patients without pre-existing cardiovascular abnormalities, prophylactic atorvastatin led to higher preservation of EF, and prospective trials are now underway. So when it comes to treatment, we extrapolate conventional heart failure therapies to patients with anthracycline-induced cardiomyopathy. In this study from 2006, 473 cancer patients receiving high-dose chemotherapy were followed. 114 of these demonstrated a troponin rise soon after starting high-dose chemotherapy. Half of these patients who demonstrated the troponin rise were randomized to enalapril and the other half to placebo. EF was measured at the interval shown here. The ACE inhibitor group demonstrated significantly less reduction in EF over the 12-month period compared to placebo. We now return to that study I showed you earlier from Italy that followed over 2,600 patients receiving anthracyclines. Heart failure therapy was initiated in all patients who developed cardiotoxicity. This was enalapril in 17% and enalapril with beta blocker in 83%. 185 or 82% of patients recovered from cardiotoxicity after a mean time of 8 months to recovery. Of those, 11% had full recovery and 71% had partial recovery. So these data emphasize that outcomes can be quite good if anthracycline cardiotoxicity is promptly detected and treatment is promptly initiated. The influence of time to heart failure treatment is further emphasized on this graph, which illustrates the percentage of responders according to the time elapsed from adriamycin administration to start of heart failure therapy in 201 patients with anthracycline cardiomyopathy who were treated with enalapril with or without carvedilol. The shorter the time to heart failure treatment, the better the chance of improvement. So we've seen that there is a dose-response relationship between cumulative anthracycline exposure and risk of cardiomyopathy, and that there's also a dose-response relationship between cumulative radiation dose to the chest and risk of cardiomyopathy. This report from the International Late Effects of Childhood Cancer Guideline Group uses these dose-response relationships to categorize survivors of childhood cancers into 3 groups based on the risk of cardiomyopathy. And they propose that cardiomyopathy surveillance is recommended for high-risk survivors to begin no later than 2 years after treatment, repeated every 5 years thereafter. And this guideline also suggests that cardiovascular surveillance is reasonable for moderate or low-risk survivors over the same time frame. However, this rarely happens in clinical practice. So let's shift gear a little and talk about targeted anti-cancer agents. Targeted agents act on specific molecular targets in cancer cells and were developed to offer anti-cancer efficacy with less collateral damage to normal cells than our traditional chemotherapies. However, targets are not only important for maintaining function of malignant cells, but also for normal cells. So interfering with these processes is associated with adverse effects, including cardiotoxicity. This table is not meant to be legible, but simply is there to illustrate that many types of cardiovascular toxicities are associated with these newer agents. So let us first consider trastuzumab and other HER2-targeted therapies. Trastuzumab is a humanized monoclonal antibody directed against the extracellular domain of the human epidermal growth factor receptor 2, or HER2 receptor. Overexpression of HER2 occurs in approximately 15% of all breast cancers, and it's a poor prognostic indicator, as these tumors tend to be more aggressive and are associated with higher recurrence rates. Large randomized controlled trials have demonstrated significant benefit from adjuvant trastuzumab in HER2-positive breast cancer, with a 50% reduction in rate of recurrence and a 30% improvement in rate of survival. However, trastuzumab is well recognized to cause cardiotoxicity. The addition of trastuzumab to chemotherapy regimens increases the incidence of an asymptomatic drop in EF to approximately 7 to 19%, and it increases the incidence of symptomatic heart failure to 1 to 4% approximately. The mechanism for trastuzumab-mediated cardiotoxicity is likely due to the fact that HER2 pathway plays a protective role against myocardial stress, and binding trastuzumab to the HER2 receptor may disrupt this protection. Risk factors are associated with trastuzumab cardiotoxicity, and these include adjuvant chemotherapy, particularly anthracyclines, advancing age, and cardiovascular comorbidities, and these were incorporated into this risk score that was derived in a cohort of over 1,600 women with stage 1 or 2 breast cancer. In recent years, other HER2 antagonists have been developed. Pertuzumab, which like trastuzumab is a monoclonal antibody, lapatinib, which is an oral tyrosine kinase inhibitor, and TDM1, which is an antibody-drug conjugate. Combination treatment using 2 anti-HER2 agents improves oncology outcomes with comparable cardiotoxicity. So how reversible is trastuzumab cardiotoxicity? Well, in this study of 251 breast cancer patients treated with trastuzumab with or without anthracyclines, 17% developed cardiotoxicity defined as a reduction in EF by greater than 10 percentage points from baseline and less than 50%. Of those, 60% recovered cardiac function with interruption of trastuzumab and starting heart failure treatments. Recovery was less likely in the elderly, those who demonstrate early cardiotoxicity, those with troponin elevations, and those with severely impaired LVEF. Re-exposure to trastuzumab with co-prescription of heart failure medications is often tolerated. So Manticore was the first randomized trial for the prevention of trastuzumab-mediated cardiotoxicity. Patients were randomized to perindopril, bisoprolol, or placebo. There was a cardiac MRI at baseline and after 1 year or 17 cycles of trastuzumab. The primary endpoint was change in indexed LV end diastolic volume, as they proposed that this was more reproducible than LVEF. So here are the primary results. Note only 30 odd patients in each group, so small numbers. The mean change in indexed end diastolic volume was similar between groups. However, the mean absolute change in EF was lower in bisoprolol treated patients compared to placebo and in the perindopril treated group compared to placebo. So the authors concluded that perindopril and bisoprolol each attenuated trastuzumab associated declines in EF but did not prevent concurrent LV remodeling, which was the primary outcome measure. Helpfully, this study did show that these pharmacotherapies were well tolerated and were associated with fewer interruptions in trastuzumab therapy. This Dutch study investigated the ability of candesartan to prevent trastuzumab-related cardiotoxicity. 210 women receiving trastuzumab after anthracyclines were randomized to receive either candesartan or placebo, and the primary outcome was EF. There was no significant difference in the rate of decline in EF between the two groups. So clearly more data is required to definitively establish the effect of prophylactic treatment, but so far trial results have been disappointing. EF surveillance is standard practice for all patients treated with trastuzumab. This is most commonly performed at baseline and repeated every 3 months throughout treatment or at any time in the event of symptoms or clinical signs of heart failure. There are promising data emerging on the utility of cardiac biomarkers, but biomarkers have not yet been adopted widely into clinical practice. The European Society for Medical Oncology published this algorithm to guide decisions on whether to continue or discontinue trastuzumab based on EF assessments, and this is the typical protocol that is followed by most oncologists. You can see that for interval reductions in EF of greater than 10 percentage points from below baseline, the recommendation is to hold trastuzumab for 3 weeks and then reassess with another echo or MUGA. This is also hopefully where a cardiologist will get involved to initiate heart failure medications. It's helpful to note that the American Society of Echocardiography and the European Association of Cardiovascular Imaging conclude that despite suggestions that alterations in LV diastolic function precede overt reductions in EF, there is no evidence that cancer treatments should be modified based on these findings. And similarly, strain indices have received a lot of attention in cardio-oncology. However, based on available literature, global longitudinal strain-based evidence of subclinical myocardial dysfunction alone is not sufficient reason to introduce cardioprotective therapies, although many people are in clinical practice, or to modify cancer treatments. So a word of caution that applies to suspected cardiotoxicity with any cancer therapy. Chemotherapy-induced cardiotoxicity should be a diagnosis of exclusion. It is important to evaluate for other causes of myocardial dysfunction, typically like an ischemia evaluation, especially in older patients who've got cardiovascular risk factors. So let us now focus on the vascular endothelial growth factor pathway inhibitors. So the VEGF pathway mediates cell proliferation, cell survival, permeability, and migration. And as such, the VEGF signaling pathway has become a major target for cancer therapies. Lenvatinib is an oral multi-targeted tyrosine kinase inhibitor that was approved by the FDA in February 2015 for radioiodine refractory differentiated thyroid cancer due to the impressive improvement in median progression-free survival compared to placebo. However, lenvatinib was associated with a very high rate of hypertension, with a 67% prevalence of all-grade hypertension and a 42% prevalence of grade 3 or higher hypertension. Indeed, the VEGF pathway inhibitors are well recognized to cause hypertension, but fortunately not all to the extent that is associated with lenvatinib. The incidence of hypertension with sorafenib, sunitinib, and bevacizumab is in the order of 25%. Proteasome inhibitors are used in the treatment of multiple myeloma. In 2003, bertuzumab became the first proteasome inhibitor to receive FDA approval for treatment of multiple myeloma. Indeed, the treatment of multiple myeloma has been revolutionized by the advent of these proteasome inhibitors, as well as immunomodulatory agents such as thalidomide, with a 2 to 3-fold increase in overall survival. Unfortunately, bertuzumab has been undermined by peripheral neuropathy and resistance, and so second-generation proteasome inhibitors have been developed to overcome these limitations. Carfilzomab is a second-generation proteasome inhibitor that has been incorporated earlier and at higher doses and more broadly into the treatment of multiple myeloma. It offers greater specificity, greater potency, and less off-target activity outside of the proteasome. However, cardiotoxicities associated with carfilzomab have surfaced as a complication of clinical trials, with increased prevalence of venous thromboembolism, ischemic heart disease, cardiac failure, and hypertension. It is important to remember that multiple myeloma is most frequently diagnosed among people aged between 65 and 74, with a median age at diagnosis of 69. And so obviously this is a cohort of patients who have a higher prevalence of either diagnosed or undiagnosed cardiovascular disease. I will make a quick comment on the immunomodulatory agents thalidomide and lenalidomide that are being increasingly used in the treatment of hematological malignancies, particularly multiple myeloma. These agents are associated with a significantly increased risk of venous thromboembolic disease. In studies, patients who took prophylaxis such as aspirin had lower thromboembolism rates than those patients who were not on prophylaxis. I will now discuss B-cerebral tyrosine kinase inhibitors. The US incidence of CML is approximately 1.75 per 100,000, and of course the incidence increases with age. The Philadelphia chromosome makes a B-cerebral fusion protein which has an uninhibited activity, and white blood cells that contain this B-cerebral fusion protein expand slowly. B-cerebral tyrosine kinase inhibitors such as imatinib are now being used with great effect in chronic myeloid leukemia. Imatinib was approved by the FDA for treatment of CML in 2001, and 5-year survival has improved from 34% in 1995 to 62.5% in 2007. So much so that CML is now essentially considered a chronic disease, and thus these patients are often committed to lifelong CML treatment. Imatinib does not have a very significant cardiac signal, but more than 20% of patients are resistant to the drug. Therefore, second and third generation inhibitors such as dasatinib, nilotinib, bosutinib, and ponatinib were developed to overcome imatinib resistance. More and more data suggests that nilotinib is associated with severe peripheral arterial occlusive disease, and this occasionally can take the form of rapidly progressive disease. These events were not only recognized in patients with cardiovascular risk factors, but also in younger patients without any cardiovascular risk factors. Similarly, ponatinib triggers arterial hypertension as well as vascular adverse events. In addition, the percentage of patients developing these vascular adverse events increases over time. And this is a particularly important observation because these patients are committed to long-term treatment with these agents. Potential mechanisms of nilotinib-associated vasculopathy include metabolic effects with an increase in cholesterol and fasting glucose levels, pro-atherogenic effects leading to arterial stenosis, anti-angiogenic effects which prevent neorevascularization and recannulation during and after vascular occlusion, vasospasm, and a combination of these effects. Risk factors for vascular adverse events are recognized. There's a dose-dependent response. Risk is also higher in those with known atherosclerosis and traditional cardiovascular risk factors. The risk may decrease with shorter exposure times. The increase in fasting glucose level during nilotinib treatment, and the risk may be higher in patients receiving certain CKIs in a sequential manner. So how can we reduce the vascular risk associated with these agents? Well, patients due to commence ponatinib or nilotinib should undergo cardiovascular risk profile assessment. We should screen for clinical signs and symptoms of cardiovascular disease or peripheral arterial disease, much like we would do for routine preoperative cardiovascular evaluations. We should obtain baseline determinations of fasting lipids, glucose, and A1C, and retain a low threshold for getting ABIs. There is a pre-treatment opportunity to identify and modify cardiovascular risk factors, and this could include considering the introduction of aspirin therapy, although data to support the strategy are not available. In high-risk patients or those with pre-existing peripheral arterial disease or ischemic heart disease, we should try and use imatinib if at all possible and avoid nilotinib or ponatinib. If there is imatinib resistance, then maybe we should try and use dasatinib or bosutinib, as they have more of a favorable vascular safety profile, or use lower doses of nilotinib or ponatinib if needed. So there's obviously been a lot of talk recently about immune checkpoint inhibitors. This is the timeline of FDA approval of immune checkpoint inhibitors in various malignancies. It's easy to appreciate the rapid expansion of approved agents and indications for their use. However, we now recognize that high-grade immune-related adverse events can occur with immune checkpoint blockade, particularly when used in combination. In 2016, we started to get the first reports of fulminant myocarditis after treatment with ipilimumab and nivolumab. This complication is thought to be rare, but the incidence is higher with combination immunotherapy. Emerging case series suggest that this complication generally happens within the first 30 to 90 days of treatment after an average of 2 to 3 treatments. Concurrent immune-related adverse events such as colitis, hepatitis, etc. are common, and myositis frequently accompanies myocarditis. Nearly all myocarditis cases had a troponin elevation and an abnormal ECG. LVEF has been found to be normal in half of all cases. LGE was seen in about 3/4 of all patients who underwent MRI. In those patients who underwent an endomyocardial biopsy, the consistent finding was a patchy to gross T-cell predominant lymphocytic infiltrate within the myocardium. So what happens to these patients? Well, of 35 cases followed for a median of 102 days, 46% of patients experienced a major adverse cardiovascular event. Cardiovascular death in 6 patients, cardiogenic shock in 3 patients, cardiac arrest in 4 patients, and complete heart block in 3 patients. What portends a poor prognosis? Not surprisingly, higher levels of troponin on admission, at peak, and at discharge. Furthermore, a higher initial steroid dose was associated with a lower rate of MACE, and it is reported that cases who died had a higher incidence of conduction abnormalities and were more likely to have received the combination of IPI and NIVO. The cornerstone of treatment is removal of the immune checkpoint inhibitor and high-dose steroids tapered slowly and with surveillance of cardiac biomarkers throughout steroid taper. Other immunosuppressants, including mycophenolate, antithymocyte globulin, and infliximab, have been used on a case-by-case basis. And this is the algorithm from the National Comprehensive Cancer Network for management of this problem. So the key take-home points are that improving cancer survival have resulted in a significant increase in the relevance and prevalence of cardiotoxicity. Cardiovascular disease is a leading cause of death in cancer survivors. There are well-recognized cardiotoxicities associated with radiation therapy, anthracyclines, and trastuzumab. Risk factors that predispose to cardiotoxicity are recognized, and so it's important that patients undergo pre-treatment cardiovascular screening and optimization, particularly prior to certain high-risk cancer treatments. For certain treatments like trastuzumab, surveillance is necessary during and after treatment with serial assessment of EF with or without cardiac biomarkers. Targeted anti-cancer therapies and immunotherapies are rapidly evolving and have significantly improved cancer outcomes, but they are associated with a range of agent-specific cardiovascular toxicities. Certain agents have the potential for significant cardiovascular morbidity. True incidence and mechanisms of cardiovascular toxicities of newer agents is uncertain, and these knowledge gaps emphasize the need for research to improve cardiovascular outcomes in cancer patients. And it certainly does make for a very dynamic field. So now let's go back to the questions. Additional anthracycline-based chemotherapy is planned for a 42-year-old lady with metastatic breast cancer and prior exposure to 320 milligrams per meter squared of doxorubicin. Current EF on MUGA is 56%. The only FDA-approved agent or agents to protect against anthracycline-induced cardiotoxicity in this patient is or are A, enalapril, B, enalapril and carvedilol, C, desrazoxin, or D, statin. The answer is C. Second question. 69-year-old lady with no significant cardiovascular risk factors is being treated with thalidomide and dexamethasone for multiple myeloma. Which of the following cardiovascular complications is she at highest risk of? A, dilated cardiomyopathy, B, prolonged QTc, C, atrial fibrillation, or D, venous thromboembolic disease? The answer is D. Third question. 69-year-old male with a history of hypertension, hyperlipidemia, smoking and COPD with an EF of 52% and abnormal diastology has been recently diagnosed with CML. Which of the following is most true about BCR-ABL tyrosine kinase inhibitor therapy? A. Serial EF assessment is recommended throughout treatment. B. Aspirin therapy should be interrupted due to anticipated thrombocytopenia. C. Dasatinib is the preferred BCR-ABL tyrosine kinase inhibitor as it has a more favourable vascular safety profile. Or D. Use of BCR-ABL tyrosine kinase inhibitor is contraindicated for this patient. The best answer is probably C. So here are some helpful references.